Let's get started. Thank you to all of you joining us. I'm sure a couple more people will be joining as we go along. My name is Adam Kaufman. I'm part of the OSP team. We're so happy to have you all with us and to join us for this really exciting webinar. It's one in a series where we tackle interesting topics in digital health, focused a lot on artificial intelligence with some of the leading thinkers in the space. So the title for this will be Digital Health in 2030, so we get a chance to look forward. Feels like a long time, but it's already October of 2025, so it's not that long from now, where we're going to focus on AI, telehealth, patient trust, and coverage. And so thank you again for joining us, and most important, thank you to Dr. Atithi Joshi. Really appreciate it. She is the CEO of Adrexia, a best-selling author, leading voice in digital health innovation, bringing over a decade of experience in digital health. I think before digital health, you were an emergency medicine physician, if I have that correct. And it'd be interesting to know if you how you are blending clinical care with what you're doing. But she created the telehealth success framework. She's been a important member of the American Medical Association Digital Medicine Payment and just a deep thinker in the space. So thank you so much, Dr. Joshi, for joining us. And let me just kick it off by saying what an honor it is to have you, and maybe you can share a little bit about your personal journey, and in particular, how that got you to digital health and telemedicine.
Yeah, thank you for having me. Excited to be here as well. And I always say that it's a series of accidents that got me to digital health, but not really. So like you mentioned, I'm an emergency medicine physician since 2009 when I graduated residency. Got burnout. It's a classic story, but at the time, around 2012, there wasn't really a lot of discussion around it. So I was looking for other avenues. I stumbled upon a startup called Doctor on Demand, which is no longer really a startup, and I became one of the first doctors, their assistant medical director, and it really introduced me to the entire world of telemedicine and digital health. And from there, I've had quite a career within digital health and also emergency medicine. I only stopped practicing about 3 years ago.
Oh, wow.
And so, yeah, it's been really interesting just to see both of those things together. But since then, aside from the startup, I've worked at an academic center, done a lot of consulting, and recently started my own company. So glad to be here.
And there's so much to cover, but I'm curious, um, did you see more in parallel and similar between emergency medicine and digital health, or is there more differences?
So I think in emergency medicine, we try to pride ourselves that we tend to be very innovative. There is a lot to that because we are an entire specialty that has to make quick decisions. And more, very important within the tech space, we also have to change our decisions really quickly if they don't work, right? This whole idea of agile. And so we do that just naturally. And when we're also trying to think through how we do things, there's a lot of things that we do naturally that I think really lend itself to digital health and technology. And then second, just in general, because the emergency room is very unique compared to a lot of different clinical spaces. We're really the bridge between the community as well as the hospital, right? So people come in from the outpatient space, from their homes, and they come into the ER, and it's either you go home or you get admitted to the hospital, or you see a specialist, right? So we're this bridging. And so we have access and we get a lot of information and we work with a lot of different types of groups. So we get a really good idea of what's out there and what the other clinical environments are like. And it lends itself to really understanding where are the pain points for ourselves, for patients, as well as the other specialists that we work with. We joke, that we know everybody in the hospital, except maybe dermatology and pathology, right? But we know everybody because we work with everybody.
Yeah. No, that's great. And I imagine from the patient standpoint, while there are accidents and there are things we can never prevent, I think a lot of what puts people in the emergency department are things that we would have tried to get upstream of. So you also have this nice view of, okay, at the end of the day, what did we not do as well because somebody came here who didn't have to.
Yes, yes. A lot of iterating. So we think through a lot of that. Uh, and one thing I'll just
So
say, there's a lot
yeah,
of, oh, sorry, I was going to just add one thing. There is a lot, we can talk about it if of interest to the audience, but there is a lot of people who assume that because you're in emergency medicine, you can't do telemedicine. And that is absolutely not true. We have proven it over and over and over again. So,
yeah, I'd love to come back to maybe some of those like very tangible, like what are we doing today? But I think maybe we'll start in the future. So as you think of that broad experience from I guess having been in the emergency department until very recently, founded a company, been at one of the early and most successful telehealth companies. Maybe tell us where you think we'll be in 2030, and if 5 years isn't enough, feel free to extend that timeline, and particularly around technology in healthcare. So is AI going to consume the world? Will everyone be in telehealth? And how do you see patients' experience evolving in that time frame?
Yeah, that is a huge question, but also really interesting. So when I was, thinking through this entire topic, it occurred to me that it's 2025 and we are in the almost the last quarter of 2025. So we're only 5 years to 2030. And right, that old adage, you assume you can do more in a year, but you underestimate how much you can do in 10 years. And so, it occurred to me that really when we're talking about AI in healthcare, it really only exploded this year. Yeah, there were murmurs and things, but the real actual discussion points really only happened this year.
Yeah.
And we're going to see that continue to grow. And when I think about just like how I look at the future, right, I think about the patterns that I saw in telemedicine and how that really has panned out so far. Just because when we tried to standardize it and make sure that it was clinically relevant and that it fit into our workflows and there is safety and that there's patient quality and quality of care, all these same things we're having in the discussion for AI. And despite the fact that we are thinking that AI is going to move faster than telemedicine, there's a couple of reasons that I think by 2030, we're probably not going to have integrated AI nearly as much as we think, because we haven't even integrated telemedicine as much as we think. Um, so for example, that we probably have right now, many, many hospitals, especially academic centers, have probably done pilots. A lot of people did it during the pandemic, but let's not talk about that per se. But, we are still at a point where we probably at max, at any institution, we probably only have like 20 to 25% of people max who are using telemedicine.
Yeah.
So if you're trying to build AI on top of that and think about, okay, how are we going to get to like an actual integration or implementation adoption to 75, 80%. We're never going to get 100 probably, but if we're going to get there, we can't even do that with something that's been around much longer. So when I think about AI, so I think that when we get to 2030, and there's a lot of parts to this, I think we're going to go a lot more slowly than we think. I think this year has been about discussing and putting it out into the culture, the society, so we can think about what does it mean, what is it, how can we discuss it? But I think we're going to come to a point where it becomes much more, what's a good word to mean that it's going to be less like cool things to talk about and much more like standardizing the fun things that are not fun, right? Things that
Yeah.
like you need to do but are not necessarily the fun part.
Yeah. Yeah. I think it's a really keen insight of how, not completely, but each kind of wave of new technology is building on what happened before, right? If we hadn't digitized healthcare, we couldn't have really done telemedicine. If we didn't have telemedicine, we probably couldn't do some of the algorithms and AI. And so I think you start layering slow adoption of each of them, and it gets slower at the end. Um, do you think one of the things that I find curious is, do you think patients will demand of us in the healthcare settings more technology, and they'll actually be pulling it? Because I think historically, maybe other than the pandemic, as you said, it's actually been healthcare trying to say this is a new technology, we want to use it, and the patients have been slower. Do you see that changing, or?
I don't see that changing, but I think it's an interesting, a step by clinician, a step by patients. And so, so oftentimes we think it's only the clinicians pushing and pulling patients forward, but sometimes it's patients pulling things forward, right? So, I think about when, like AI specifically, right? So when we talk about when we use it for decision making or just as a diagnostic tool, I think a lot of doctors may use it to check,
Yeah.
and in fact, actually, probably not even a lot of doctors. Let me go back a second. But people who are using it, experimenting with it, they're testing it out, right? We want to see, does this work? Is this really what we want to use it for? Because the actual clinical decision making is much more difficult. But patients actually do use it, right? They type in their symptoms and they want to know, is this valid for me? Now, whether or not that's the right thing to do or is helpful, that's another story. But I do think that because patients are now being able to use it for that purpose, it is going to force us to try to catch up with that. I think, mental health specifically is a really great example. I
Yeah.
heard some study that was like, or some like survey, there's like 50% of people use a therapist on ChatGPT, for example. So in that way, we're going to have to make sure that whatever that clinical decision making is going to pull us forward. But I think in general, for other types of things, using devices, using telemedicine, and patients don't necessarily know what's out there, what could be possible. And we have to be able to offer it to them. And I think that's the information asymmetry that just exists in medicine overall. Even if they're using these tools in other parts of their life, it isn't always clear how they can use it for medicine, right? I just think about when people ask me what telemedicine was. This is 2012, 2013, and everybody's already using FaceTime. But everyone was like, how can you do that for medicine? And it's like, well, it's the same, but right. So it's going to be those type of conversations that we're going to be having.
Yeah, I like that step of a patient, step of a physician, because I know a lot of physicians who were bullish on telemedicine, but I still need to see the patient. And then all of a sudden they're like, well, actually maybe I can do that because the lab came in separately, or I don't need to see them. So I think that's interesting. I- I'm curious, you spent a lot of time and were instrumental in kind of building out the telehealth success framework. Maybe you could share a little bit about that and maybe describe to us how frameworks that are sort of structured centrally and can deploy are also part of what helps drive adoption.
Yes. So the framework that you're referring to is out of a book that I co-wrote with the CEO of Doxy.me. And it's basically just 5 pillars. And it was based out of experience that I've had from building out telehealth programs in the past. And it really
Yeah,
is it's just like a very easy way to organize yourself. And so we use it to that degree. And so, you start out with the patients and like, what do they need? But if you're like going to deep dive, it's almost like you're talking about what do they understand about it? What is their quality of care? What actually is useful for them? Um, and so, we each of these frameworks, each of these pillars, like bring out these questions, right? So the other ones are clinician, which includes not even just how do you practically do telemedicine, but how is your organization structured? Who's the leadership team? Who are the people who are actually doing the um, building of these programs? Because that really makes a difference in how well clinicians are going to be able to use it. And then the finances, the technology, and compliance. And compliance tends to be the catch-all for things like malpractice and regulations, and how do you avoid fraud, which we're seeing a lot more of these stories about Medicare fraud, or people using telemedicine for Medicare fraud. And so, it's the whole idea if you're going to be trying to build out, how do you just stay organized to make sure that you're not lacking or
yeah,
forgetting something that's necessary? And then when we talk about AI, I was thinking through after like living in here, I was like, well, what does AI require that isn't part of this? And I think that what I would add is actually a data and intelligence, like data and data intelligence part of
yeah.
a pillar, because that isn't technology specifically, right? And I think it's also different than the way that we think about clinician processes and protocols. And so for that, you have to think and add that for AI because it is a huge, it's not a problem, it's a huge area and really needs to be thought of differently as well.
Yeah. There's a lot in what you said, so maybe we can unpack a couple. I think we take for granted how hard it is to be the first in anything, but particularly something that's technical driven, and how just natural learning happens. And so those who have blazed the path, like you have in telemedicine and now in other areas, coming back and saying, here's what we've learned. This may not answer everything, but this is some best practices that get you 60, 70%. Like it's so much a part of that next generation of doing it. I like to say that, sort of when some of us started in telemedicine, like, or digital health, no one had done it. So like you couldn't go hire an expert in digital health. And now we've been doing it long enough that people have
Yeah.
done it. So maybe talk a little bit of just like how you've seen the pillars being used, and how just even writing down those sort of best practices helps accelerate that technology adoption. And then we can come to what you're saying about another
Yes.
pillar for AI.
Yeah. So just in general, when I describe it as, I don't, people who've written a book have probably realized this. It's like getting all of the things that are sitting in your brain, all these notes and playbooks you have on the side when you're doing your job and your work, and you're just putting it on paper. And it feels like it gives you a little bit of relief for your brain because it's now out there. And it's really just the way that, I would have to build this from the ground up. And I will
Yeah.
state that, a lot of the way that we think about any type of health program in medicine or any type of program we build tends to have a lot of these components, but we're not always very cognizant of the fact that this is what we're actually doing. So when I think about how did I use it in other places, what I really think is interesting is that yes, I got a lot of my experience in the US, but I've actually used this in other parts of the world,
Oh,
mainly
wow.
because, when we think about um, the US experience, we really went from like the ground level up. But a lot of other places, they did do it too. I'm not going to say we were the only country doing telemedicine this entire time, but when the way that we built it out, there's a lot of other places that are trying to skip some of the steps that we had to learn through. And I think that's great. So, for example, I was building out a program in the Middle East. And so when we were talking through how do we, figure out the uh, ability to actually cross connect between different departments with technology, they actually already had that really, but it was really trying to get them on the same one so they could actually use that. So it wasn't really a
It
question
was a
of,
different problem to
yeah,
solve. I
yes.
guess, same problem, different structure of what needed to be solved for, maybe.
Yeah. And I think that's what's useful about it, right? Because for me, I'm like, oh, well, that problem I understand. I just have to make sure that it fits into this part of the framework. That was the problem actually was the clinicians and then the regulations, right? So that actually ended up being a much bigger problem over there
Interesting.
than was the technology. But I will say in general, the technology generally is not the problem.
So maybe sticking with that, and I put a pin in it. We'll come back to the AI pillar because I'm very interested in it. But so I think we talked a little bit of how people having had experience sharing best practices can accelerate digital adoption. But what are some of the things that block it? So you mentioned sort of clinical buy-in, some of the regulatory. Maybe say a little bit more, and what in your experience are sort of the main things that keep us from doing this even faster, even with the interest or goodwill to do it.
Absolutely. So I think traditionally a lot of it was just the feeling that it was not safe to do or do over technology. The finances, right? So how do you get reimbursed when that was a very classic one that people were like, well, I can't do this without the reimbursement. It's time, right? It's time, it's effort, and I have to figure out how to use this within our system. And then obviously there was the worry about malpractice and then whether or not patients want it. So I'll start there because I think with those particular four areas, a lot of that has been essentially solved, right? So we have at least some reimbursement. We are yet again in the process of trying to figure out if it'll be extended, but these things tend to happen. And we do have the financing, right? So we do have reimbursement. We set it up. People want it. Both sides of the aisle want it. So it's really, really one of the few things that's
Hopefully, wait,
bipartisan.
you'll avoid politics today. It's a bad day to
For
think
sure. But
about. I think the
telemedicine is
government's still
bipartisan.
shut
That's
down
all I'll
as of
say.
12
Yes,
30
whatever.
Eastern.
Yes, exactly. Fair enough. But at the moment, people like telemedicine is my point. And then, with the malpractice, we found that it's actually not really like I do some chart reviews for telemedicine cases, and often it's not the telemedicine that's the problem. It's like the follow up in the ER that tends in, well, I chart review for ER as well. Um, but when I think that one of the adoption, and I think the barrier that we're seeing is that the adoption rate for clinicians, and I mentioned this very briefly in the beginning, is that we're still sort of stuck at this like 20%. And so when we're trying to actually make a real digital healthcare model, like actually make sure that telemedicine or other digital tools are part of healthcare practice, we kind of get stuck at this like number.
Yeah.
And it tends to be because either like, we don't have a good understanding of how to use these tools. And honestly, clinicians can really block it because in the end, you can have leadership tell you what to do, but the reality is most doctors, we do not tell each other not really how to practice. As long as you're hitting the standard of care, we do not actually tell other people what they have to do, right? You have to be safe, and etc. And I think this ends up being the biggest barrier that I've seen. And I do think that in the next couple of years, this is going to be the thing that we have to overcome the most. And just, yeah, I know we're going to talk about AI later, but this actually becomes much more obvious in AI, like much more
Hmm.
obvious than it was in telemedicine, because doctors are very resistant and well, they're worried about safety, right? And so it becomes resistant to that.
Well, let's do this. Just thank you again to everyone on. We'll go about 20-ish minutes more in our conversation, but we invite you to send questions in and we'll open it up. So if there are things that the audience is interested in asking Dr. Joshi, please send them in and we'll get to them in about 20 minutes. So maybe sticking with this concept of physician resistance. that potentially being a bigger issue in AI. Maybe say a little bit about, maybe come back to that pillar that you said, we would add this to make AI work, and then describe to us where you're seeing that resistance and how we might overcome it.
Yeah, great question. So I'll start with just the resistance in general. And I always try to describe it as when any of us are trying these tools out, let's say we're using it for our daily health or whatever we're using at banking, it tends to be an individual decision. But when physicians have to do it, right, you're making a decision, for someone else in some degree. And so we tend to, in general, tend to be a little more risk averse because of it. We want to make sure that whatever is given to us is going to give us the right decision, right? And also, when you have all of these discussions about where is the data coming from? Is it biased? Something that's definitely become much more obvious within healthcare and much more of a discussion point over the last decade, but we haven't really solved it, right? We're still trying to overcome that. And so now you're putting all of that data in there. And then, lastly, is that when we think about regulations, part of the fear is that if we are being forced to use it, how do we know where that data is actually coming from? And that might be this is going to be a problem probably not right this minute, but there have been rumblings about, are we going to be like, if maybe an example, so that if a doctor is going to see a patient and they don't use AI, let's say, and something happens, are they going to be liable for not using AI? But on the flip side, if they do use AI and something happens, are they also going to be liable? Like, what does that mean, and who's going to actually be liable in this?
I'm
And I
smiling. I don't
tell
know if you
this,
saw this, and it may be related, but I can't remember if it was LA Times, maybe police officer pulled over a Waymo, and they're like, who do you give the ticket to? So like, a little bit of like, all right, well, if
exactly.
the AI is doing this or didn't do that, who's responsible? So it's
That is funny because I'll be honest, I've been in a Waymo. They drive very slowly and very
yeah, I
carefully,
wouldn't
so
they
I
do
don't
go
I don't
out of
even
the
know what
lane a
happened.
little bit if someone's there. Like I assume they follow the
Oh,
rules, but if they don't, like who gets the ticket? So anyway, it's an interesting way to think, because I think we have much more visible experience of an autonomous car, at least those of us who live in cities where they have them. But it's a similar
right,
idea, right? Which is something did this, who's accountable? So yeah, sorry, I didn't mean to
right.
interrupt. It made me think of
No,
that.
it's okay. But this makes healthcare much more. This is why it's so complicated, right? Everyone's like, if you're trying to do something, just make money, this is not the place to come because this is really a complicated space. It's worthwhile, but it is a very complicated space. So, yeah, you're talking about like when you're trying to overcome this fear, and then, we can test it out, right? So, I use a couple and you test it out. I always ask questions, specifically emergency medicine ones that, the answer to just I'm curious, right? And depending on them, I've definitely found the one that's specifically geared toward doctors does work fairly well, but it also tells you which journals are coming from. But again, right? So you have to know what you don't know. And then
Yeah.
the fear is that we don't really know what's in those black boxes. Like you can't actually ask just because you're an expert in one thing in medicine, let's say physicians, you can't ask them to be an expert in the technology behind AI and then ask them to take responsibility for it. It reminds me of a story. So I was in HIMSS EU, and so they asked the exact question. It was actually an emergency medicine question. A patient calls in, gets an AI answer for a set of symptoms. The AI tells them one thing, that they can sit at home, it's fine. Well, anyway, a couple days later, they're not fine. They go into the ER. Um, and they're sicker than they should be, right? So uh, the patient had, spoken to an EI. They got that one particular answer. The AI actually told them that they should probably go see a doctor. No doctor actually followed up on that chart that said that. And then obviously the hospital had approved this particular AI. So we had this discussion, right? Who is liable? Is it the AI company who built this out? Is it the health system that approved this AI app? Is it the doctor who didn't follow up and make sure the patient came in? Or is it the patient who was told to go to the hospital and then didn't?
Yeah.
So, it's funny because like for me, right? So I was the American, and most of the people there, they were like, it's really the health system's fault and also the AI company's fault. They should have like had a better algorithm. And then the health system really, they're the one that approved it. And I was just thinking to myself, man, in the US, the problem with this clinician barrier, this physician barrier, is that we would be blamed for it, right? And so this is what actually makes it much harder to get people to want to use it because we have this understanding, even if it's not obvious yet. It's just the way
Yeah.
that we're set up. So those are all of a couple of reasons that it does that. But
And I think it's a simpler example, but it's a really good one, this idea of triage, right? Like where should you go get seen as sort of like a, are you okay? Wait till Monday, go see the doctor, go to the emergency room right now. Even that, like, um, and yet I agree with you. Those are there's some clear cases all the way, but there's some edge cases that like you could ask a bunch of experts, they wouldn't know. You could give a patient recommendation, they wouldn't do it. And so um, I think your point is a good one. Is you could see why. Well, if it's not clear what to do all the time, but it's automated. I think what we lose though sometimes is if we don't put some of these tools in, nobody's going to give that person an answer, right? Like they're like, there's just
right,
not enough
that's
nurses or
true.
doctors to answer the phone to do it. And so I think that's the argument too. I'm curious though in that story. So the physician trust. Do you see trust from patients growing, or do you see as we see more examples of the unfortunate cases of people with AI therapists who haven't gone well, or these cases, like will trust erode with the patients for AI?
Yes, well, I think trust is eroding, but it isn't even necessarily because of digital health. I think we all know that there's a lot going on that is creating this building of distrust and mistrust of medical information, physicians, healthcare. And some of it, has to be the responsibility of the House of Medicine, right? We talked about bias. We talked about certain groups not getting the right type of care. The research has been done on certain populations and not others. I mean, those are real things. So,
Right.
in that way, there has to be a responsibility that is taken by medicine itself. But in general, we do always try to improve things, and I think what is getting lost in this entire discussion about whether there is trust is in physicians is that almost like every single one of us actually want to do something better, right? We are dealing with individuals. We look them in the face. We want them to get better, and so we
Yeah.
do want this to improve also. And so that seems to that is like one thing I want to very much stress because there isn't any doctor out there that's holding out or not trying to do something because they really do want to do better. And so I do think there are other forces that make this much harder to create, right? We are in a place where algorithms can make us believe in certain things. We're not all seeing the same news. I mean, there's a lot, but what we can actually control is really what we can think about. But I will say that one thing that digital health has to do, telemedicine has to do, and even AI tools, there has to be a recognition that patients often come to us because they do want that human connection. So let's say, like we're giving the example of, using AI for triaging. That's all great, but eventually they probably do. Let's say they're really worried about it. They just want someone to take that time to speak to them.
Right.
I do not know if, there's all these movies and theories that we can get rid of that with an AI that's tailored to you. I don't know if that's true. I hope not, but I do hope that like that is something that is converted. I will give the last example, just with like when you talk about the therapist that you were bringing up, the AI therapists. But if you look at the way that it talks to patients, the reason that they feel like they can trust it is that it sounds like a human who actually cares about them, right? So that shouldn't get lost in this whole idea that we're using AI for mental health. It's not because it's AI that people want to use it. It's because it's giving them something. It's not always giving them the right treatment necessarily for therapy, but it is giving them that feeling.
My father's a physician, and when he
Hmm.
retired, he tells the story. Someone asked him, does he miss practicing medicine? And he said, I don't miss the curing, I miss the healing. And I think, maybe that captures what you're saying, which is before AI, most of the technology we were talking about, whether it's clinical decision support, computer vision, was about doing the curing better, faster. Maybe you didn't need as much people. And I think it's interesting that some of what we're seeing in AI is actually moving into the healing, the empathy. And I think to your point, it'd be interesting to see whether in some cases that can replace human beings or that's an adjunct to it because we hadn't reckoned with technology that was empathetic in the way that we go to our clinic, right? You go to a great clinician because you want to be cured, but you want them to do it in a way that also heals you, I think. And
Yeah,
so I think that's probably unique in AI. Maybe if we
absolutely.
transition a little bit about building this, maybe you can share your experience both inside a health system, at a startup, at your own. Like, where's the work being done between startups, between the big tech companies, between the big health tech companies inside of a hospital, inside a clinic, individual doctors. How are we moving forward, and who's doing what parts of this?
Yes, it seems like everyone's trying to do everything, but that's not actually true. So, I'll say, the reason I took the academic job that I took in 2016 to run telemedicine, this is Thomas Jefferson, was because the entire premise there was that if you are going to use digital tools, it should come out of where physicians practice, like physicians should have a voice in it. And so I bring up that example because when I think about like where people are building, so you have these like large academic and health systems, and they do one of two things, right? So that's what we used to do. We would either try to build it ourselves, we would have a startup lab, or we would take in other people's platforms, but we would build out the programs ourselves, right? But we would try to figure out what does this department need, what is like the nursing department need, what does ENT need versus neurosurgery, things like that, that are going to be easy to do at a large health system. And in those places, you're going to see the knowledge go quickly in the way that a digital tool can be used in a broad and diverse set of places. So that's one thing to think about. What I think startups, well, I'll separate them from big tech, obviously, but I think what startups do is they kind of give you a pulse on where there's at least funding happening and what people's ideas are, or sometimes it's also where the problems are in the healthcare system, right? Because if you're seeing a lot of solutions for people who have diabetes and cannot get medications, or they cannot get readings, whatever it is, you see a number of companies that are trying to solve this problem. It gives you an idea that yes, this is happening. And then of course, there's going to always be sometimes useful information you can get. Unfortunately in this space, not every company can make it, right? But sometimes it'll be used at a health system to see whether is this something that's useful for the healthcare system, or is it going to be something that can integrate it for something else? So I think that really is a really interesting part to see in the startup space. And then with the big tech companies, I mean, they're really good at building out interesting tech, right? When you think about even AI, and when we're looking at how it's used in clinical care, I mean, the first use cases were from Google Images, right? They were the ones who were actually training. I think they were doing, it was in ophthalmology, right? They were looking at pictures, basically the back of the eye, and they were trying to look at diagnoses of whether someone might have diabetes or something like that,
I
or
remember
hypertension.
that.
You
Yeah,
can look
I
at the back of
was.
the eye. Do you remember?
They were
But because
also
they had
trying to
billions of
see.
images.
Have you seen these pictures where they've got croissants and Shar-Peis, and you're trying to train whether the image is like a
Which one?
Shar-Pei curled up or a croissant? I remember those too.
I don't even see that one, but I do remember hearing about this and I was like, oh, that's really interesting. But what I thought was interesting, I saw a lecture, I think it was South by Southwest, but one of the speakers from Google was saying that we were actually able to tell whether the eye was from a woman or man. And it's something that I would never have thought about because, if
That's
you're doing an
interesting.
ophthalmology exam, you're like literally like
Yeah,
right
yeah.
face, right next face. So it's
I
nothing,
never heard that
yeah,
eyes were gendered. So, but
because no one would have thought I didn't realize
yeah,
it either. And I've never heard about it again. I never investigated that, but that was just really interesting that it could actually find maybe these differences that we don't know. And so I think there's a
yeah,
tremendous amount of potential with the amount of data these big tech companies have and the level of engineering they have, right? But they are not healthcare companies. They are not necessarily interested in the best outcomes for society and patients. And so all three of these together have to work together, right? Like, so you have big tech that can think of these technologies. You have health systems that can test it out. And then you have startups that can, help with like trying to figure out what are the real problems on the ground that people are seeing that we need to fix.
yeah. So a reminder to the audience, please start sending in your questions. We'll go 5, 10 more minutes. So sticking with these different groups, there's some overlap, but they're really focusing on solving different problems. Maybe share some examples of collaborations that you've seen that have been successful, and any tips for those of us who are thinking about doing collaborations of what to avoid.
Oh, yes. So, that is a big question. It's like how much time, but I will, I'll say a couple of things. What I think um, what's useful for like and I'll give it from the perspective first of a healthcare system, but when you're, or any actually program that's building, because I can use the examples in the Middle East as well. But when you're coming in with different types of technology, right? So you have to think through like what is going to be necessary. And so it's not going to be just one answer. So big tech companies or big companies, right? Because it's not necessarily just tech, it's cable companies. There's all sorts of things that are necessary for building out digital health and hospital systems. You can actually, you sometimes are going to need these bigger companies just because of the scale of what you're trying to do. So it's just being very clear, where is it that you cannot skimp and get like a smaller avenue and get really just something that has the breadth to be able to fix a problem that you're trying to do. So, you really have to know the problem really well so that you can actually get that fixed. I think with startups and when you're looking at what you're trying to do, I think the problem, and I've seen this often, is that um, so let's say I go in, you go in, you try to make a very clear framework or list of the qualifications for the technology you need based on what the program is you're trying to build. What I find happens a lot is that we tend to overestimate some of the things that are um, less important and underestimate things that are, right? So you actually want to be able to use something that can be used in, if you're a big system, right? You want things that can be used in multiple departments, let's say, because what you don't want is each department needing a different type of solution. So in the event of telemedicine, it has to be something that can do scheduled visits, it can do acute care, it can do unscheduled, all of those things. But people tend to overestimate then like what kind of bells and whistles that go on it that are maybe not necessary for the clinicians to do their job, right? So, what does the note look like specifically? They almost all look the same. Like if something is just a little bit different, that's not going to make that big a difference. That could be fixed, right? So just like making sure that is like at least the most simplest, easiest, and useful thing for you to actually implement into your station, because I'll tell you, that'll make a difference on how well adoption goes as well.
Yeah.
And then one last thing I'll just add to any of this is that if you're going to do this, you just need to have the right leadership. Because yeah, we talk about getting the diverse voices. We understand that you need the clinician voice in there, but you also need the right leadership as well.
Yeah, and if I could extend that leadership thing, I think the collaborations are hard. We all know that even collaborating inside your own organization is hard, but across organizations, that leadership is so important, but also to know that there's an alignment in the sort of direction and the vision and the strategy of the organization so that that is a meaningful collaboration. I don't know if you want to kind of add to that as well.
Collaborations.
No, more the idea that
Yes.
you might technically be aligned, but if one group is doing this to own the data and mine it for another thing, and the other one, like there needs to be alignment at the organizational sort of vision, mission piece, at least for the projects, has been my experience, or those big collaborations fall apart as well.
Yeah, absolutely. And I think we're seeing this too. This is going to be an absolute must if we're trying to use AI, because even in telemedicine, right, we want to share the data. But I'll tell you, the reality is like, someone is like, oh, I want to open a cancer, just a quick diagnostic cancer telemedicine program. Trying to learn from other people's data is actually not necessarily as helpful as it would be for an AI program that's trying to do something with like, triaging, for example.
Yeah.
And so I think collaborating, and for me, like the most important thing is trying to figure out if the people are willing to share data. I don't have an answer for this because people seem not to be willing to share it.
Yeah.
It does help a little bit when, let's say in the same town or community or area, people on the same EMR, there is some ability to see back and forth. But I think this is going to be another big barrier to what we can do. This is why, you add data intelligence, that last section.
Yeah, really, really insightful. So we got a minute or two more before we go to questions. So just to come back to it, if we look 2030, 2035, we'll take the 5 or 10 years because, as you said, we tend to overestimate what can get done in a year and underestimate in 10. What are some of the big trends? Maybe we've hit some. Are there things we didn't talk about that you think we'll be looking at 5 or 10 years from now and saying that those really made a big difference for whether it's the patient experience, the clinician experience, or outcomes more broadly?
Yeah, I think the biggest thing that would be really helpful with all of these tools is making something personalized. And that can be both the personalized tech tools for each patient, things that are important to them, but also just like the actual personalization that we're going to be seeing in genetics and the actual personalized type of healthcare that's going to happen. But, if we're talking about digital tools specifically, right? So, some people are going to need, let's say, just at the basics, like what kind of healthcare they're going to need, the type of devices and things we'll have figured that out by then. We really should have. And then second is that the type of interactions that they're going to want. I will not say that we're going to get rid of doctors completely, but I do think just because I don't think that's going to happen in the next 10 years. But I do think that that the way that we practice will be very different. It's going to be more of a collaborative space, which is great. We want that based on these centralized places where patients can have their personalized hub of their own healthcare. What I do worry about, though, is that whether that's only going to be certain populations that get access to that, it really depends on whether we can make this type of access to like apps or phones that will have this type of care available to everybody. It should be much less expensive by that time. So even for like basic care, like preventive care, I'm not even talking about like, specialty care, but even preventive care, I see it there. I do think there's going to be a lot more ability to use some of these tools for diagnosis, but I will not say it will fully take over diagnosis. I just don't think that we will feel that we will trust it enough, even in 10 years. We will use it more, but I just don't think we're going to get there.
Yeah. We didn't get into it. Maybe it's a topic for another conversation. Are we going to be able to make these tools available for everyone? Are we going to, in some ways, separate or segment the healthcare system? I think is a big question because, in a worst case scenario, you end up with care that looks one way for one set of people and one way for another, and not everyone's there. I think we all hope that doesn't happen. I don't see any reason it has to, but I don't know if we've prevented that. Um, but so thank you. Let us go to some of the questions, and I'll pick up one because you mentioned personalization in your answer. So Debbie writes, personalization is one of the key aspects when it comes to AI. Is it possible that we have too much personalization, and does it essentially kind of deprive someone of options if there's too much in that reliance on AI? So I think the question is around if we get so N of one, do we actually lose the ability to kind of actually think at the population level, which is where healthcare came? And so maybe some reactions to that.
Sure. Thanks for the question, Debbie. I do think there is that reliance, and we didn't even touch on this, right? Is our this trend that we're having of relying on these tools and cutting ourselves off from community, which actually is paradoxically makes our mental health worse, right? And so when I think about personalization, I definitely want to keep it separate, like the whole healthcare aspect versus an entire personalization where it is only your one companion and that's enough for you. I do not know, and that's a really good point that you bring up, is I do not know how do you actually make that different? Because if you are going to personalize healthcare, which is very unique to everybody, and it's also very personal and it is intimate as well because it's private. If you're going to be able to do that, that means you're able to personalize AI to a degree that would probably take care of all of these other type of social needs that humans have. And so I do think there is that risk. And I don't want to ever come to that point because we're already seeing many, many reasons for how that is making everyone's mental health and loneliness worse.
Yeah.
I would like to separate it out. Let's hope we can do that.
Yeah, probably a whole nother conversation about how we maintain community connections and that interaction
Mhm.
because some of the interventions themselves are community interventions, right? Like, I mean, certainly public health has been that way, but I think a lot of the mental health ones are go to an exercise class together, you physically feel better, but you're also, socially connected. Um, in Sebastian's question, I'm actually surprised this didn't come up as much. So Sebastian's wondering, do you see the next wave of digital health or telemedicine being even more tightly connected to the EHR? Or are we going to be able to be EHR agnostic? And maybe a broader question is, is the future going to be what Epic it tells us it is, or are we going to be able to innovate around the EMRs?
Yes, thanks, Sebastian, for that question too. And right, because Epic came up with their big AI announcement as well, so that's also been in the news.
Neural
But
ambience
I'll say
thrive,
for
right?
Oh yes, exactly. So I'll say this about just in general. In general, we have been EHR agnostic in telemedicine for most of the time. Most places actually use other telemedicine platforms for much of their telemedicine, or at least they have access to it, right? So if you're doing telestroke for acute care, we didn't use Epic either. So, because part of the reason is that when you have these EHR tools, going back to the entire thought process around, are you picking the right tool? Is it actually integrated here? A lot of these EHRs are not built, they're not telemedicine platforms, so they're not exactly doing that. Now, saying that, Epic does work for telemedicine in certain avenues. And so you can use it for some parts of it, which we did as well. So I'll say that in general, that if like you're trying to integrate into an EHR, I want to separate out what we mean by integration, because I think that ends up being why this ends up a talking point over and over, is that you have the actual tech integration, right? So you have like the data integration into absolutely into Epic. So it seems like it's already there, but actually that's much harder to do. And you need a lot of the permissions from Epic and all of these companies as well. But what most people go around and they do, and what we talk about from like a clinician standpoint, is you need like a workflow integration. So it doesn't actually make your job harder. It is
Yeah.
easier, right, if it's in the Epic already, but if it's not, just make it easy until there is like an actual solution. But uh, I just don't think that it's there yet. Yeah, if they can make something that monopolizes the entire world, yes, we can see it, but they haven't done it yet. So even when they talk about the ambient scribe, I'll say, people are really worried about it. I was like, you just test it out first, because that's not that they're doing it, but that's not what the only thing they do.
So I think Benedict's question follows up on that sort of how are you successful from a clinician standpoint, and asks about AI or virtual care platforms, even digital health more broadly. Sometimes clinicians feel that it adds to their workload, and that it doesn't actually reduce cognitive load and reduce burnout. Can you say a little bit about when technology is helpful for clinicians, and maybe the design of technology
Sure.
that actually isn't helpful in that way?
Yeah. Hi, Benedict. Yes, that's exactly the crux of the problem with clinician adoption. Because I'll be honest, most of the time it does add to the workload. It hasn't really gotten to a point where it makes everything more efficient, because we don't have enough adoption for it to really have like changed the healthcare system enough that we are just using it and it's part of it, right? So you think about telemedicine, people report that it makes their day a little bit easier, breaks up their in-person clinics. They can do shorter visits because it's generally shorter on telemedicine than patients coming in. We did an interesting study where we compared antibiotic prescriptions in the ER versus our urgent care versus telemedicine. And we gave less prescriptions on telemedicine, and likely because patients were less upset about not getting an antibiotic prescription if they weren't waiting 4 hours as they would in the emergency department, right? And we had the ability to just explain to them, you don't need this now. If you have a problem, you come back. There's a lot of reasons why it works. But I'll say that, most of the data for most specialties shows that telemedicine saves them time except primary care. Unfortunately,
Hmm.
it does not lead to shorter visits with them, which is unfortunate because they tend to have a lot of burden on them already. And
Well, they
then
have
when we
such
talk about
short
like other,
visits to begin with, right?
yeah, yeah, exactly. And so I think maybe, they're trying to get it in. It's just, unfortunately, it's not shorter for them either.
Yeah.
But when you talk about like one thing that recently has been shown to improve, just excuse me, clinician timing is ambient AI, because it does help with the actual charting. But one thing I will say is that, it goes back and forth. There are studies I've read that say that, but, anecdotally, people say it doesn't, and I get anecdotal. But I've also, heard the worry that what it's actually leading to is chart bloat, meaning it's just making these nodes hugely long and making it
Mhm.
harder to actually sift through, because then
Yeah.
you have all of this data in there as well.
Well, now you need
So
AI to sift through the AI
to
generated
sift
node,
through
right?
it as well. Yeah, exactly. But at this point, I don't know about you, but I'm like looking through the whole node still, because you never know. So I think this is a great point. We are not there yet. I feel like everybody's still at a 1.25 type of like cognitive load because of it.
Yeah. I think one of the things, and first, thank you all to the questions that are coming in. I unfortunately I don't think we'll get to all of them. So Aditha, if you're open to it, maybe we'll have you back, and we'll just run a Q&A.
Absolutely.
But so we had an anonymous question come in, and maybe I'll link it to some other thoughts, but really about digital health companies and some of the bigger companies, not getting funding or not succeeding. We should say that in parallel, we've seen a couple of them go public and do well as well. So maybe your sense
Yeah.
on how thinking about funding success or lack thereof is moving, what that could tell you about the industry.
Yes. Thank you, Anonymous, whoever you are out there. But I think part of the problem, right? So we're seeing just a decrease in all the funding overall. And it's interesting, right? Because generally healthcare is considered recession proof. But what what happens is that, we are still generally, um, again, risk averse. So if let's say, there's a health system, like the example I gave earlier, they would rather actually try to build it themselves or work around it than they would want to actually buy and invest into a pilot. Also, we're at a place right now, unless something is very new and different, a lot of places, healthcare systems, organizations already have a bunch of tools, and they're trying to figure out how do we use the tools that we already have, or they should be trying to figure out how do they use the tools. So when you look at like some of the failures in funding, I mean, I do see that one, it ends up that they're just not able to actually penetrate the market. It may also be that they're not actually building something that anyone wants. I think people have gotten a little bit more sophisticated. That is happening a little bit less. Or they're competing, and there is a very narrow difference between companies doing the same thing. And, a lot of times it's going to be a lot of factors that are not related to the actual product, even that are going to make people successful. And I think when we look at VCs, the ones that I've talked to, they're seeing that. And so they really want a sure bet. Um, and like this year, right? So we've seen a lot of funding go to AI companies because people think it's going to be the sure bet. And again, I'm like, this is not going to be forever. So who is going to actually win it? You can't actually we don't need 10 ambient AI companies, right? We need one that works really well or a couple that work really well, right? And so I do think that there is still going to be a little bit of hesitation for a little bit of time.
Think maybe we've got one or two more questions. So, Sienna nicely brings us back to your telehealth success framework, and a really interesting question of those pillars. And I think you said there were five in the original, and you've added maybe a sixth, although I haven't written the next version of the book. Which are you finding the hardest for health systems or healthcare organizations to get right?
Yeah, thanks, Sienna. I'll say it a million times. It's the clinician part. We have figured out, patients have a much more bigger recognition. And once they have a recognition, it becomes a lot easier to try to tell them. And not all patients want it. That's okay, but they know it exists and they have the option for it. But clinician, I cannot tell you the amount of people I've talked to. They're like, yeah, we cannot get past this percentage of our clinicians using these tools that we've had for even 5, 6 years, maybe even a decade. And I do think this ends up being why a lot of people lose out on ROI. A lot of patients don't get access to this type of care or care at all because of it, or they don't have these digital tools. Because the other parts of it tend to be either very national or state level, the regulations and the reimbursements, but the clinician one tends to be the stickiest. But I think that is
Yeah.
true for every part of innovation in medicine, because again, like I said, we have to think through a lot more, and we tend to be a little bit risk averse.
So maybe we'll take this as the last question. We'll ask it, but can let you kind of blend it into any closing thoughts. So Newman writes, what will be the most significant changes in AI and telehealth for 2030 that will change the way we deliver care? And then I'd love any closing remarks, anything we didn't cover as we sort of wrap up where we'll be in 5 or 10 years.
Right. Yes. Thank you, Newman, for that question. So I think in general, in 5 years, what I think we'll see is hopefully finally there's going to be a much more standardized and much more ubiquitous ability to get telemedicine. We are still not there, right? So first, getting more access so people actually can see telemedicine. And what there is a movement toward is making it so that it isn't actually so patient individually based, meaning it's not being catered specifically to patients, it's being offered by patients' doctors. And that's what we need for that to work the best. And when we talk about AI, again, because in 5 years, I just don't think we're going to be at that decision making, but I do think what will happen is that for telemedicine visits specifically, we're going to see it be able to do the intake. So we get a better idea of like maybe what level patient is. And it may not triage them to say you go somewhere or you don't need a telemedicine visit, but it triage them to just give you a better idea of where they come for. Two, I think the language interpretation services, that's going to be there because even just checking out or if anyone's tested the language services, they have gotten much better. Every year they get better and better. So I think that would be huge, right? Because you have the access to a language interpreter and then it would be in the app itself. And then I think lastly, there will be the ambient AI part of the telemedicine as well, just because it is much better for everyone to get that. What I am hoping for, and I don't know if we'll get there by 2030, is to have a better data intelligence database, being able to share from all of the digital tools that we have, but also from all of the AHRs. That is a dream, that last one, but the first three, they seem very simple, but it's because, I don't overshoot for the 5 year mark. And then I think over 10 years, like I really do think that eventually all of these tools are not going to be considered different. I do believe that not even to hype it, but I do think AI is going to be a significant change. And once you get to that level of technology, it's going to be very difficult for some other technology to come in and say, wow, this is going to change everything, right? Because AI tends to be the base or is used as a tool in everything. So let's say, we do everything in virtual reality or we do robotic surgery, and there's been an incredible a couple of surgeries recently that have been doing it. AI is still used within it. It isn't going to be different. So it's almost going to be like the future of what all of the other technologies are going to be able to do, but not a different technology itself. So
That
yes,
was,
thank you.
I, again, like three or four more conversations we'll have to have. That I thought I mean, all incredibly interesting, but I'm glad you brought up the sort of real time translation. I think that is something we haven't reckoned with. Aditha,
Mhm.
thank you. I am so glad we worked out our technical and, in my case, travel challenges to do this. To the audience, thank you all so much for joining us and spending the hour. Hopefully, you'll thank Dr. Joshi as well. For those of you interested in learning more, you can visit the OSP webpage, check out the resources that they have there, upcoming webinars, and we're excited to continue this conversation. So please feel free to reach out, and we're excited for future conversations. So thank you again. Really enjoyed it. I hope everyone has a great rest of the day, and we'll talk again soon.
Thank you, Adam. It's my pleasure. Bye bye, everyone.